This conference will now be recorded.
So when we look at, let me make sure the screen is showing. Yes. When we're looking at the nervous system and neurotransmitters, the main thing that we want to know about is the structure. So I'm going to borrow a business card of mine where somebody isn't sitting. Perfect. So I want you to think that you all are neurons. Neurons are cells of the brain and spinal cord. So their job is to send information to other neurons. So in this room, there's about 20 neurons, right? So say, for example, and this isn't the case, but say, for example, in order for you to get your CEs or, your CEs, you have to email me to get them. This is hypothetical, of course. So in order for you to get your CEs, hypothetically, you would have to email me. Well, in order to email me, say you didn't have my business card. I'm going to pass around my business card and everybody's going to write down my information, right? So then you can email me and say, give me my CEs. Well, the neuron is going to send this information around the room, this business card, which has specific information on it, so that everybody gets it. And then some sort of action is taken, right? So if you look at the neuron, this being you, the first part of your neuron is your finger-like projections. They're literally your fingers of you. So finger-like projections are called dendrites. Their job is to receive information from other neurons. So if I come up to, what is your name? Patty. If I come up to Patty and I say, okay, I'm going to give you my business card, you're going to reach out exactly how she just did with her finger-like projections, which are her dendrites, and she's going to take that information from me. She received it, right? That's how a dendrite works. Now, once she receives the information, she has to do something with it. She has to integrate it. How is she going to do that? Well, that information she takes in from her dendrites, she's going to look at it, see the email, and integrate it with her brain. The brain of the neuron is the cell body or the soma. So that is where we integrate information that we receive in from our dendrites. Okay. Now, there's a long tube-like structure that goes down you. So you can think of it as your torso. That is the axon. That is going to send information, an impulse, down to the end of the neuron where there's pockets. So think of it as the pockets of your pants, or, if you're wearing pants hypothetically that has a pocket. Each of us have different business cards, right? Because we're different people. So we all have our own different email. We have our own different phone number. So the business cards are stored in our terminal buttons. And I'll show you a picture of this shortly, which are our pockets. So at the end of the neuron is your terminal buttons, where these neurotransmitters, or the business card, is stored. Then what happens is we release this neurotransmitter or business card into the space between you and the next neuron. So what is your name? Cindy. And you are? Michelle. So the space in between Cindy and Michelle is the synaptic gap. Okay? This is where problems happen. So we'll talk about that in a second. So I'm neuron 1. I say, okay, I want to send a specific message, which is information for Cindy to get her CEs. I fire. I release from my terminal button or my pocket this business card or the neurotransmitter that has specific information. Boom, it goes into the synaptic gap, or the space between Cindy and I. Cindy takes her her finger-like projections. She takes it in through her finger-like projection, so she's receiving that info. She's going to look at it, see the email address, process it or integrate it through her brain, which is the soma. Then she has to reach a certain threshold of energy so that she can now fire that message onto Michelle. I'll talk about that in a minute. So she reaches the energy enough for her to fire or send that message into the synaptic gap. And now Michelle is ready with her finger-like projections, takes that business card, looks at it, and then the firing keeps happening throughout the whole room. So by the time that message gets to all you neurons, you know where to email to get your CE. Make sense? I'll show you a diagram. So, take my neurotransmitter back. Okay. So here's the diagram. This is neuron 1 on the left. So that's me. To the right is neuron 2. That's Cindy. It's a great picture of you, by the way. And so you can see the synaptic gap in between these two neurons. So me being the one on the left, neuron 1, I receive information through my dendrites, or those spiky things on the end. I take that information in and send it to the soma, which is at the center here. That's the brain of the cell. A whole bunch of electrical activity happens, which we'll talk about shortly. And here's your axon that goes all the way down. It connects this base here to the terminal buttons at the end. It's surrounded by nice, cushy myelin sheath to keep that nice and cozy for electrical impulses to travel down. So when I say, okay, I'm highly energized enough to fire, I send that electrical impulse down the axon, boom, to the end, so that I stimulate these terminal buttons. Now, within the terminal buttons are the neurotransmitters. Those are your pockets, remember, of your pants. So in those are your business cards. So I stimulate, I release from the terminal buttons that neurotransmitter into the synaptic gap. Here's Cindy. The goal is for that neurotransmitter to cross, to bind to Cindy's dendrites here, and then the process continues to everybody. Make sense? Okay. So this is where problems occur, why people need to take medication. So sometimes what happens is we release the neurotransmitter into the synaptic gap. And what happens is it's here in the synaptic gap and it gets sucked back into its own terminal buttons. So if I have my business card and I release it into the synaptic gap and Cindy's ready with her finger-like projections and I go, and I suck it back in, put the business card back in my pocket, now what? She's not going to get the information, so now none of you are going to get your CEs, right? Because you're not going to have the information to email me. So what that process is called is reuptake. Reuptake. So it cannot bind to the next dendrites because it's being sucked back in. That original neuron, that first neuron, is sucking it back into its own terminal buttons. So there's nothing to bind to the next neuron. That is called reuptake. So many of you probably have heard of medications called Zoloft, Paxil, Prozac, Lexapro, Celexa. Those are called selective serotonin reuptake inhibitors. So what that's saying is reuptake is happening of serotonin. So we're going to give you this medication, like I mentioned, SSRIs, or selective serotonin reuptake inhibitors, so that it forces When I release my business card or my neurotransmitter into that synaptic gap, it forces it to bind to the next dendrite of the neuron so that everybody gets the message. So why do people take SSRIs? We'll talk about that later, but some of it could be pain. Some of it's depression, some of it's anxiety. So by taking this medication, now it's saying, oh no, you're not going to allow it to suck back into your own terminal button. I'm forcing you to connect to the dendrites of the next neuron. So many people say, well, I'm taking serotonin pills. No, you're not. You're taking a medication that is preventing the reuptake of the serotonin you have. Okay? I'll talk more about that later. The second thing that can happen is, say, for example, not to put the person on the spot, but who's the person that just walked in? Raise your hand. Excellent. You're not being shamed, I promise you. Okay. So say, for example, I release my neurotransmitter into the synaptic gap. What is your name? Colleen. I release the neuron into the synaptic gap. And now Colleen walks through those doors, grabs this business card and tears it up. So rude, right? Now what? The message isn't going to get through to everybody, right? Choline is an enzyme. So sometimes enzymes will release, well, what we'll do is we'll release the neurotransmitter into the synaptic gap, and enzymes will come in and break down that neurotransmitter. And now there's nothing to bind to the next neuron. That's the second problem that can happen. So some people may take a medication that is going to block that from happening. It's going to lock the doors so that choline, aka the enzyme, can't get in to come in and rip up the business card. Make sense? Okay. So before I talk about the other things that could possibly happen, I want to talk about some principles of neurotransmission. So all or none principle says either a neuron is going to fire or it's not. So in order for a neuron to fire, it has to reach a certain threshold of energy. So in order for us to get out of bed in the morning, we may need caffeine to give us some extra energy to get out of bed, right? So we have to energize to a certain point to get up, get out of bed, do things. Well, that's the same thing with neurotransmission. So say, for example, I want you to think of it as a light switch. The light switch that is on or off. Some people say, well, what if it's a dimmer? Okay, let's not look at that, okay? So let's say that you're looking at a light switch and it's either going to go on or off, right? If you switch it on, it goes on, you switch it down. It has to reach a certain point when you're lifting the button for it to go on, right? Okay. So either it's going to go on or it's not. That is all or none process in neuronal firing. What does that mean? Well, let's say in order for a neuron hypothetically to fire, it needs to reach, say, 65 microvolts. Think of a switch as being 65 microvolts. Here's the switch to where it's going to go on or off. If I energize to 60 microvolts, am I going to fire? No. If I energize to 75 microvolts, I flip the switch. It doesn't fire any stronger. It just flips the switch. That's the all or none process. It just needs to flip that switch. So what happens is now I fire and I release my neurotransmitters into the synaptic gap, and then the process is going. Well, there's a period once I fire and release my neurotransmitter that no matter how much I stimulate, I could stimulate now to 100 microvolts. I'm not going to fire again. Just think of it as you flip the switch first, and that switch stays open. No matter how high I stimulate to 100 microvolts, wherever I go, I cannot fire. That's called the absolute refractory period. What that says is, regardless of the amount of stimulation, I cannot fire. How I teach my students this is I say, think of it as, I absolutely cannot fire again. The absolute refractory period. After that period, the switch comes down, but it raises. So boom, 65 microvolts, I set it off, go through the absolute refractory period. No matter how high I stimulate, I'm not going to fire again. That switch comes down, but it raises. So now only very intense stimulation is going to allow me to flip that switch again or fire. That is called the relative refractory period, which says only very intense stimulation will allow me to fire again. So that you can think of it as we flip the switch and that switch is now higher. Yes. Yes. So this is where we run into problems. So I already talked about reuptake, where we release, one of the problems could be we release our neurotransmitters into the synaptic gap, and then it sucks it back into its own terminal button, and that's called what? Reuptake. Good. Or the second thing, Colleen comes in the door late. I'm not shaming you. And, I live in California now, so everybody's like, whatever. They show up 30 minutes, 40 minutes late. It's like, whatever. In New York, it's like, no, you are going to be here. If you're not here on time, you're fired, right? So that's why I'm chill. So you can thank California for that. So release it. Colleen comes in, rips up my business card or the neurotransmitter. Nothing passes. That's because Colleen is an enzyme. The next reason why people might take meds is because this neuron, the initial neuron, is firing too much. So it's going through the absolute refractory period and the relative refractory period fast. Boom, 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 boom. What does that look like? Anxiety, rapid speech, rapid movements, racing thoughts, racing heart rate. So somebody needs to take a medication that is going to slow down the likelihood of firing, or it's called an action potential. So you'll hear me say an action potential is the neuron firing, or an action potential is, you'll hear me say, just firing. So they need to take a medication that is going to say, slow down. You're firing too much. An example of that are beta blockers, like Inderol, that people take for tachycardia or rapid heart rate, right? It's going to say, we need you to slow down. Sometimes it's too slow. So it's like it fires, and that absolute refractory period or the relative refractory period is too long. It's like, wait for it, right? Eeyore, hello, right? Slowed speech, slowed heart rate, slowed movement, slurred speech. So they need to take a medication that's going to say, speed it up. I need you to be faster. You're spending too much time in that absolute refractory or relative refractory period. We need you to speed up. Epinephrine, right? Yes. Correct. Yes. Correct. There's another thing that could be why people have to take meds. Sometimes it's firing fine. Everything's releasing fine. It's firing fine. It's going through the periods fine. But the neurotransmitter is too potent. It's too strong. It's too effective. So now they have to take a medication that's going to say, all right, neurotransmitter, I need you to be less effective. Because if we slow it down, then it's not going to be enough. So we need to tell it, I need you to be less potent. On the other hand, it may not be potent enough. It's firing fine. If we make it fire any faster, it's going to cause symptoms. So we need to just take a med that's going to say, I just need you to be a little bit more potent because you're not potent enough. Pain, right? So you are, riding your bicycle, you crash into something, your leg is killing you. We have natural endorphins that are going to help kill the pain, but it's not enough. So sometimes we have to take a med that's going to tell the endorphins, I need you to be more strong because you're not strong enough. You're not stopping the pain. This, you're going to learn, I'm going to talk about this over and over. This is why I save cardiac and all those meds to the end, because it's going to be like, well, if it's not this, then this. This is why many people will start on one med and then they'll go to another med and they'll go to another med, and people get frustrated and they're like, why do they keep changing meds? They should just know what it is. Well, we can't, on most things, figure out what the problem is because we can't see it at that level. So we're going to try and say, okay, I'm going to give this med to speed things up, and it doesn't work. Oh, maybe we need to give something that's going to tell the neurotransmitter to be more potent, not speed up. Yes, it works. So, as a review, information comes in through the dendrites or the finger-like projections. That information is integrated into the cell soma or the brain of the cell to say, this is what we need to do to fire. Then it reaches a certain threshold, it fires, so it sends an electrical impulse down the axon to the terminal buttons. In the terminal buttons are stored neurotransmitters. It releases, by that stimulation, it releases the neurotransmitter into the synaptic gap. And the goal is for it to bind to the next dendrite and the process continue. Sometimes where we have problems is that we release it into the synaptic gap, it's sucked back into its own terminal buttons. Therefore, the message isn't binding to the next dendrite. That is called reuptake. Or enzymes come in and break it down, the neurotransmitter. So now it cannot bind because there's nothing to bind. Or the neuron is firing too slow, so we need to speed it up. Or it's firing too fast, so we need to tell it to slow down. Or the neurotransmitter isn't potent enough or strong enough for whatever the outcome we need to be. So we need to take a med that says, I need you to be more potent. Or it's too potent and we need to take something that's going to say, okay, I need you to be less potent. Got it? Okay. I'm going to repeat this throughout today, so don't worry about it. We'll keep going over it. So now we want to talk about what are those neurotransmitters that we have in our body. Well, there's two types of categories: classical neurotransmitters and peptide neurotransmitters. Classical neurotransmitters we're going to start off with first. So the most prevalent in our body is acetylcholine. Acetylcholine, its primary role is voluntary movement and memory. It's stored primarily in the hippocampus of the brain. So what is the hippocampus? The hippocampus is in charge of consolidating short-term memory into long-term memory. Short-term memory only lasts 30 seconds. People think a week, a day, hours. No, it's 30 seconds. Otherwise, our brains would be overloaded with information. So the hippocampus brings things from short-term memory and consolidates it into long-term memory. Now, the interesting thing is that with memory is that many of you working with your geriatric patients will say, how come last week so-and-so said that when they were a child this happened, but then this week they're saying that same situation, but it happened differently? This is why. Say I met with all of you 2 weeks ago and I said, tell me about your high school graduation party. What did that look like? And you tell me. And then today, 2 weeks later, I ask you again. You are not going back to when you were 18 or 17 to that graduation party in your brain. You're going to the last time you remembered it, which was 2 weeks ago. So when we pull things, the hippocampus will then say, okay, this person is trying to remember something, so we're going to bring it from long-term memory back to short-term memory. That's when you remember and state it. And then what happens is, after you state that memory, it goes back into long-term memory. So this is why memory is a problem. Because, say for example, and we all have these stories, I still don't know now who flushed the goldfish down the toilet. Was it my oldest sister or my middle sister? Because when I was told the story, the middle, or I'm the baby, the middle sister, or my next oldest sister, she said, I got in trouble when we were a kid because our oldest sister flushed the goldfish down the toilet and told mom that I did it. Then my oldest sister said, no, you did it, but you blame me. And so now I've heard this story like 10 times, and I'm like going from short term to long term, bringing it back to short term. But within short term, we can manipulate information. So when we bring something from long-term memory back into short-term and say now mom says to me, no, it was the oldest sibling. Now that's interference. So now I go, oh, okay. And I code it and put it back into long-term memory saying, no, it was my oldest sister. So who did it? We don't know unless we were there, which is why in expert testimonies, when us as psychologists are on the stand, they'll say to us, is it possible? Is there any way possible that this person saw a red car when it really was green? Yes, it is possible. It is. Because somebody else might have told them it was red or green or whatever, and then they took it from short-term memory, put it into long-term memory. That is a possibility. And now the person's like, but I'm telling you, I saw green. You've had these conversations with people, right? Where it's like, no, it was this. I'm telling you, it was this. And they're like, no, it was this. And you're fighting because each person brought it into long-term, brought it back to short, and now somehow there was interference. That's the hippocampus. That is acetylcholine. Acetylcholine now is linked to Alzheimer's. So what do we see with Alzheimer's? They have difficulty with memory. They can't remember what they ate for breakfast this morning, but they may be able to remember their 21st birthday. Why? Because short-term memory, to bring it into long-term memory, needs acetylcholine and the hippocampus. The problem with Alzheimer's is the plaques and tangles that's in the hippocampus that's preventing them from bringing that short-term into long-term. So with the plaques and tangles, what happens is there's less room for acetylcholine, so acetylcholine gets booted out. So low levels of acetylcholine are linked to Alzheimer's. As we know, the only way that we can know for sure that somebody has Alzheimer's is a brain biopsy, which is very dangerous. They'll most likely die, or an autopsy and they're already dead. So what happens, as you know, with Alzheimer's, it's very, very slow progression. So by the time it's recognized as Alzheimer's, they're in the middle stage. So they are given things like Aricept to slow down the progression. It can't reverse it. It can't stop it, but it's going to slow down the progression of the Alzheimer's. Now, what happens, though, is many of you may have seen this where they're taking their meds and then somebody says, like their caregiver or whoever, it's not working. So they pull them off. Now, we know that Alzheimer's is an insidious or slow onset. It's very slow. But when they pull them off the meds after a week or so, boom, you see that rapid progression. Now you try to give Aricept or an Alzheimer med, doesn't work because they've already progressed so far now because of not taking it that you can't go back, and now it's too late. So they have to be consistent with their medications. Catecholamines are the next category of our classical. These are our fun ones. We like catecholamines. Dopamine, epinephrine, norepinephrine. These are synthesized from tyrosine and phenylalanine. Tyrosine, we see that you can purchase over the counter as L-tyrosine. Whenever you see an L-something, L stands for levo, L-E-V-O. So levotyrosine or L-tyrosine, what the L or levo means is synthetic. So when we go to the drugstore and we see L-tyrosine, we purchase it, we take it, we are giving ourselves a synthetic form of tyrosine, which we already produce ourselves. So what's the pro of it? Well, it does improve quality of nerve impulses and neurotransmitters, so it keeps that myelin sheath really, really nice and coated. Helps with stress, mood, alertness, libido, motivation. However, because tyrosine is related to catecholamine, specific dopamine, this is where we have our first problem that can happen. Let's take our Parkinson's patients. Parkinson's patients, say for example, are taking levodopa or L-dopa. Why? Because Parkinson's is a degeneration of the basal ganglia of the substantia nigra, right? The basal ganglia holds dopamine, it stores it. Well, as there's a degeneration, you think of it as a holding tank. As there's a degeneration of that basal ganglia, there's less and less room for dopamine to be stored, so they're depleted. So low levels of dopamine are associated with Parkinson's, right? Because of the degeneration of the basal ganglia. So they give them levodopa or L-dopa, synthetic dopamine, so that it Jedi mind tricks the body into thinking that it's producing its own dopamine. How many of you have seen Parkinson patients start taking meds and they start experiencing hallucinations or delusions? Right? Why? The dose is too high. And how do I know that? Because higher levels of dopamine or potent levels of dopamine are what we see in schizophrenia. So if the dose is too high, if they dose them too high, you will see them start experiencing hallucinations and delusions in Parkinson's. So they have to start off very, very low on the dosage. How is this linked to tyrosine? Well, say for example, you have a patient that is taking L-dopa and they come in and they say, so my niece told me that she heard that tyrosine or L-tyrosine over the counter will help with Parkinson's. Is that true? Yes. Because the catecholamines are synthesized from tyrosine and phenylalanine. So you will see that happen. However, so your patient says, so I went out and they're on L-dopa. I went out and I bought some L-tyrosine and I'm going to start taking it. The first thing you're going to say is, have you talked to your doctor? Because now they're double dosing. Because it is a form of, or tyrosine, L-tyrosine is going to give them that synthetic dopamine. Do we see right now patients with Parkinson's taking L-tyrosine? Yes. Many physicians are now starting with L-tyrosine, and then eventually they will transition them to L-dopa. So some may be on a dose of L-tyrosine and also a small dose of L-dopa, but it's being monitored. They can't do this on their own. And then eventually they'll pull them off of the L-tyrosine. So you may see it, but they have to be very careful not to do it on their own. Geriatric population, they have a different mindset because they were raised with different medical knowledge. Things have changed, so they think over the counter is safe. That's what everybody used to say. Or it's not going to bother me, it's not going to harm me to take over the counter. Well, it could. So this is one of the first interactions of today to look at is L-tyrosine with L-dopa. Phenylalanine is a food derivative. We get this in beef, cheese, milk products, legumes, nuts, peanuts, sesame seeds, tofu, aspartame. Has anybody ever worked with somebody with PKU or phenylketonuria? Okay, it's rare. I do get people here and there. PKU, we don't see as much, especially now. One, it's rare, but two, we weren't able to test for it back in the day prior to a baby being born. What it is the baby's born, it's a genetic disease, and they cannot metabolize phenylalanine. And if you can't metabolize something, you can't excrete it. And if you can't excrete it, you become toxic and die. So what would happen, we see with PKU patients, why you may have seen them, is motor dysfunction or speech for our SLP, speech dysfunction, because they were exposed at birth to milk products, which is phenylalanine, They became toxic. Now, some of them died, some of them didn't because they caught it in time. So those individuals have to go on a PKU or a phenylalanine-free diet. Well, if the catecholamines we need to function, dopamine, norepinephrine, epinephrine, what does somebody with PKU do? Since they can't use phenylalanine, they take L-tyrosine because that is different. They can metabolize that, and it will allow them to get the catecholamines that they need. So dopamine is fun. We like dopamine. It's reward related. This is why people get addicted to things like methamphetamines and uppers, because it's pleasurable. They're not necessarily addicted to meth itself. They're addicted to meth that is making dopamine prevail. So high levels of dopamine are fun. This is why people feel good. You see them, they get very manic on meth. They hallucinate. They have delusions, right? If they're high on meth, because it's potent levels of dopamine, which is what I mentioned earlier about schizophrenia. It's a vasodilator. So it's going to increase blood flow. You all and us in general, this is why therapy, physical therapy, occupational therapy, speech therapy, psychotherapy, why using rewards is important. And how you use rewards a lot of the time is you're doing a really good job. So if you imagine that somebody says to you, you know what, you did a really good job. That person wasn't able to speak. They had a stroke. We didn't think that they would ever be able to speak again. And you as the OT or SLP have really helped them. Now they're speaking. You did such a good job. It feels good, right? It feels good. When people say, I don't like to be praised, they're FOS, full of shit, because we get a dopamine rush. So imagine the first time you fell in love and you're on the phone till 5 o'clock in the morning, and the person says, you have to get up at 6 o'clock for work or school or whatever, and you're like, I'll sleep when I'm dead. And you get an hour's sleep. You wake up, you feel great. You're like, sleep is overrated. I'm energized. I'm motivated. Life is good. Everybody's like, oh, you're gloating. You look good. You have great skin color right now, right? And they'll say like, oh, they're in love, right? And then 6 months later, you're dating the same person and it's 10 o'clock at night. And you're like, I have to go to bed. I have to be up at 6 a.m. And the person's like, I thought you said you'd sleep when you're dead. And you're like, I'm not waiting that long. That's dopamine. So you peaked when falling in love. Dopamine and oxytocin is raring. You peaked. And then eventually you came down back to your baseline. That's what it's like for people to have that rush. It feels good. So what does that help with? Well, you increase blood flow, you're vasodilating, you're moving, you're like, yeah, I feel good, right? Runner's high. Motor control, movement, nausea, sexual functioning. So I always tell my students, motor control, movement, you're going to want to go, go, go. Nausea, you get lovesick. Sexual functioning, great in the beginning, you get married. Wah, wah. Right? So when somebody's they had a stroke, say, and they're about to make that move, and you're like, come on, you can do it. I know you can do it. You are stimulating dopamine. And now they make that move. Versus if you sat there and you're like, you know what, if you can't do it, don't worry about it. That's not going to be motivating. They're just going to be like, okay, right? Whereas if you start saying, come on, you can do it, you're vasodilating. And how you're vasodilating, you're rewarding them, you're motivating them, which is going to tell the body, I need you to stimulate dopamine. Then they're going to vasodilate, they're going to increase that blood flow, they're going to move. We don't want updates. I don't know what, how is that coming up? That's so weird. Okay. So again, dopamine is prevalent in the basal ganglia of the substantia nigra. So what does that mean? Well, again, with Parkinson's, if Parkinson's is the breakdown of the basal ganglia, there's going to be less and less storage for dopamine. So they're going to have to replace by taking a synthetic dopamine to give them that dopamine they need to function. Potent levels, which are also higher levels, are associated with schizophrenia. ADHD. ADHD is associated with low levels of dopamine, but not in the same way as Parkinson's. And this is why. Parkinson's, again, breakdown of the basal ganglia. That's not what's happening in ADHD. What's happening is we see that the frontal lobe isn't lighting up because it's not getting the dopamine it needs. So what's happening? Reuptake. So a stimulant, which we'll talk about later in more detail, but a stimulant like your amphetamines, your things like, and your methylphenidates, so Ritalin, Adderall, Concerta, all of those are called dopamine reuptake inhibitors. So it's telling dopamine, I need you to bind the next neuron so that you light up the frontal lobe so that the person can be attentive or whatnot. We just call them stimulants, but underneath it, they're dopamine reuptake inhibitors. So to give you an example of ADHD that you may see with your geriatric population or any person that you know or whatnot, if they have ADHD, people say to me, well, why would you give a stimulant to somebody who is hyperactive? It's a fair question. So this is the answer. With ADHD, it used to be ADD. ADD, why they called it that, was because the person would check out or they would lose attention or they'd be disorganized or distracted, right? Well, they found that there was another type of ADHD where the person was hyperactive. Be all over the place. They'd be like energized. They'd be like motorish. They'd be, constantly on the go, just all over the place. It's the same thing. It's just presenting itself in a different way. So if there's low levels of or lower levels because of reuptake, and I give a stimulant, the person that is all over and like energized is going to calm down because now they have the stimulation they need. They don't have to run around and do all of this to kickstart their brain because that's what they're trying to do. The person who is inattentive that checks out, you give them a stimulant and now they're focused. So sometimes if a stimulant in a person that has ADHD is too high of a dose, they'll get sleepy. Whereas somebody without ADHD, if they take a high dose of a stimulant like meth, they get high. So how you can think of it is this. Say a person without ADHD is at their baseline here, and a person with hyperactivity is functioning up here. They're like all over the place, right? You give both of them a stimulant. This person doesn't have to do this anymore, so they'll come down. The person without ADHD will go up. So that's how stimulants work for ADHD. For the intent and purposes of talking about meds later, positive versus negative symptoms. What I mean when I talk about this is think of your baseline level. You come in today, you're pretty alert, even though it's 8 o'clock in the morning, right? If I add something to you, to your baseline, so I give you hallucinations, I give you rapid speech, I give you muscle twitches, that's a positive symptom because I'm adding something to your baseline. If you come in cheerful and that's your baseline and I remove that and now you're flat, affect, that's a negative symptom. I'm removing something from your baseline. So a lot of people think positive symptoms are good, negative symptoms aren't good. No, it's just the origin in which how they work. And I'll explain that when we get into some of the medications we'll talk about. Norepinephrine. Norepinephrine increases blood flow to skeletal muscle. So later on today, I'm going to talk about a certain thing that you all do or may do in your treatment. And I'm going to say it increases blood flow to the skeletal muscle. What neurotransmitter are you tapping into? And you're going to say norepinephrine. It reduces blood flow to the GI system. If we increase blood flow to the skeletal muscle, we decrease blood flow to the gastro, that equals fight or flight, right? So we're tapping into, with norepinephrine, we are activating our sympathetic nervous system. And I'll talk more about that later. It's very involved with sleep and mood regulation. Serotonin, or 5-HT. You can purchase 5-HT over the counter as well. 5-HTP is what you'll actually purchase. Anybody who's taking anything that works on a serotonin receptor, so it could be an SSRI or selective serotonin reuptake inhibitor, it could be an SNRI or serotonin norepinephrine reuptake, anything that works on serotonin, they have to be cautious if they are going to take 5-HTP over the counter. They need to talk to a doctor or pharmacist first, because they could, like tyrosine with L-DOPA, with serotonin and 5-HTP over the counter, what can happen is they can dose themselves too high. It becomes an interaction, and they can go into what's called serotonin syndrome. Serotonin syndrome is very unpleasant. They will get nauseous, they could vomit, they'll have the nystagmus, or the shifting of the eyes movement. They can experience tremors. They will not feel good. So this may be something that you know that they're taking an SNRI, say for pain, and they say, oh, I heard that 5-HTP over the counter helps with pain or sleep or aggression or mood or sexual functioning. Is that true? Yes. I think I'm going to take that. No, you need to talk to your doctor first. Serotonin's produced by tryptophan. So we left tryptophan season a couple of months ago. Turkey, right? Somebody asked me if there's an interaction between eating turkey and taking anything with serotonin in it. No, because it's not enough. You would have to eat a lot of turkeys to have an interaction there. Now, I'm going to give you a nice example of how serotonin and norepinephrine work really well together with a certain disorder. So in the early 90s, when fibromyalgia first was being looked at, but they hadn't called it fibromyalgia yet, they said these people with frozen shoulders or muscular pain, they said it's in your head, you're depressed. And these poor people were suffering in pain because of their fibromyalgia. And they said, okay, we're going to put you on an antidepressant. Now, these people really thought, well, maybe I am depressed. Maybe that's what they talked them into it. Well, they started with Elavil because that was the big drug back then, Elavil. And the person improved. Elavil is known as an antidepressant. So they said, oh, thus you must be depressed. No. Elavil works on serotonin receptors. So what was happening is serotonin receptors involved with pain. So they were making a link back then that these symptoms were somatic, that Elavil is helping, so thus it must be that they're depressed and experiencing their pain somatically or their symptoms somatically. That's not true, as we found out later. So then came SSRIs out, Paxil specifically. So these group of people said, we don't believe that it's helping because they're depressed. We think that there's something medical that we just can't see. So what if we, now that we've come out with SSRIs, work on reuptake even more, because that's probably going to help relieve their pain even more. So they started prescribing Paxil, and it was even better than Elavil. Then they said, well, this is a muscle issue. It's a neuromuscle. There's something muscular with them, why they're freezing their shoulders, they're in pain, they can't get out of bed. What if we tap into norepinephrine too? Because norepinephrine isn't going to increase the blood flow to the skeletal muscle. So it's going to help to warm up the muscles. It's going to help with movement. So there's a drug that was out at the time called Remeron. It still is out, but Remeron is a serotonin norepinephrine reuptake inhibitor. So they tried it with fibromyalgia patients, and it worked even better. So they said it's the serotonin with pain. The norepinephrine is helping now to increase that blood flow. So SNRIs are the way to go for fibromyalgia, specifically Remeron. Whenever that happens and they find the perfect thing or almost perfect thing, the drug companies go cha-ching. So they started doing a bunch of research about Remeron, and they said, we're going to make it even better. And they did. And they came out with Cymbalta. Cymbalta, as you know, or may not know, was first FDA approved for fibromyalgia, even though an SNRI is in the category of an antidepressant. Just because it's in that category doesn't mean that's why it's used. So, to give you another example, there is a pain med out there that's specifically for, that they'll say this is for pain, that primarily functions as an SNRI, but it has a very, very mild opiate to it. Does anybody know what it is? Tramadol. Exactly. Exactly. So why they say it doesn't help them is because for an SNRI to take full effect, it takes at least a month. Even though it has a very, very mild opiate, they're hoping that mild opiate will kick in right away. so that they would feel less pain. Most people say, no, this doesn't help me. And because it takes 4 to 6 weeks for it to fully take effect, the SNRI part, well, the doctors say, I don't want you on this more than a month. It's not going to work. So this is the problem. Yes, they shouldn't though, because of the opiate, because it'll help them sleep. But trazodone, which sounds like tramadol, is what they use. So in this case, again, serotonin modulates pain perception. It's used for chronic pain management, especially the SNRIs are working on both the reuptake of serotonin and norepinephrine. Fibromyalgia, Cymbalta. Cymbalta is also used for migraines. They're using it now. They are starting to use it to help, and it was FDA approved to actually work as an antidepressant, so they're starting that. But originally it was developed for fibromyalgia. Now, that is the end of our classical neurotransmitters. I'm going to talk about peptide neurotransmitters very quickly, and then we'll take our first break. So peptide neurotransmitters, there's over 20 of them. These are our natural painkillers. We call them endogenous opioids because we create these opioids ourselves. Now, GABA, or gamma aminobutyric acid, it is one that we create that is inhibitory. It's going to slow down the likelihood of an action potential. So it's going to tell, say for example, when we talk about neuronal firing, it's firing too much with pain. So we want GABA to kick in to slow down the firing, which is why it's called inhibitory. Inhibitory is going to slow down the likelihood of the neuron firing. And if we do that, we're going to relax. So our muscles are going to relax, tension. So GABA is very big with neuropathic pain, especially in the spine. But it's not enough on its own. So what do? We take something like a benzodiazepine, Valium, Xanax, Librium. These are all in the realm of benzos. We'll talk about those later in more detail. Klonopin. So they are called GABA agonists. And I'll repeat this later. But an agonist is going to tell a neurotransmitter, you aren't potent enough, so I need you to be more potent. So with pain, if we take a GABA agonist like a benzo, we're going to tell GABA, I need you to be more potent so I don't feel pain. Originally, benzos were for anxiety, Valium, but they found the pain relieving effects, partially because it would calm the muscles, it would relieve the tension, which would take the pressure off the spine. So an agonist is going to tell a neurotransmitter, I need you to be more potent. In this case, it's GABA. If GABA is naturally inhibitory, it naturally will slow down the likelihood of an action potential. And I take a GABA agonist that says to GABA, I need you to be more potent, it's going to slow down and be even more inhibitory. I'm going to repeat this over and over because, again, by the time we get to the end, I want you to have the terminology. So we will go over this. So what I'm going to do now is I am going to